of the nurses who will conduct your lung and thorax examination. So as with all the systems, when we do our examination, we start with inspection, palpation, percussion. So we listen to the front side of the patient's anterior chest and then have the patient turn and do this over again on the posterior aspect of the chest. So when you're in a clinical aspect, you might choose to inspect and listen to both sides at once and then do the anterior side and then turn the patient around and do the posterior side. So again, first we do inspection of the anterior chest, looking for his breathing. So we're looking for the breathing. We're looking for the rate of the breathing, his effort in breathing. Is it rapid? Is it shallow? Is it even? Or if patient looks to have no acute respiratory distress. So next thing is to palpate his chest. So while I'm palpating, I'm going to look for any subcutaneous air trapping. So you just palpate. So next is we do the what we call the tactile fremitus. So by using the palmar aspect of my hand, I'll place it in the intercostal muscles and have the patient saying 99 while I'm doing the 6-pack pattern inspection.
99.
So the tactile fremitus is the vibration of his words coming through. So normally we feel those and it should be symmetrical from side to side. It is more important to compare one side to the next side, especially when you are dealing with the lung and thorax. So the fact is, present is not as interesting or significant as it is present and symmetrical between both sides. So the next part of the exam is the anterior lungs is to auscultate. So I'm going to use my stethoscope and the diaphragm of my stethoscope, and I will auscultate the lung fields. So when you feel the stethoscope placed on your chest, I will have Kai take a deep breath. Okay? So I will start with the anterior chest, then listen and note where I place my stethoscope approximately in the same area on the opposite side. Okay, so I start the examination about the clavicle, where the anterior lung fields are. And then I had him take a deep breath. So note that in women, because of the breast tissue, it's hard to do a good assessment. So normally you would ask the female patient or someone with a lot of like breast tissue to lift the breast tissue while you're listening so that you can get a better assessment, or you can listen accurately on the lung field. So next, I will have the patient turn around and assess his back. And then I will take a look at the back side of his chest. Again, I will start with the inspection. Kai, can you go turn around? So again, I will start with the inspection. Making sure that I'm looking at the chest rise symmetrically and fall down symmetrically, looking for the rate of work of the breathing. So I look at the intercostal muscles, the use of the intercostal muscles, and then the next is I will do a percussion of the lung fields. So do this on the, so it is a little bit harder to do this on the anterior side because of the musculature of the anterior chest wall and the breast tissue. So with the percussion, you want to stay away with the scapula. Obviously, that is going to be a dull sound. But so when you do the percussion, you use your non-dominant hand and place it on the area and percuss using your middle finger, and then strike the DIP joint of your non-dominant hand and then release. So this is like quick tap and release. Do it on the other opposite side. So don't muffle the sound, and it should be nice and resonant sound because the lungs are filled with air. And if you palpate over the rib area, you're going to get the dullness because it is going to be a dull, bony sound. So if you want to palpate in between the ribs and the intercostal muscles, you have to percuss down. So you have to mop the borders of the lungs to get the idea where the lung tissue ends. So the next step will be called the diaphragmatic excursion. So this maps out the diaphragmatic movement during full inspiration and then full expiration. I will have Kai take a deep inhale and hold it. So while he's doing that, I will percuss down and mark the area where it changes from resonance to dullness. And then if you have a pen, you can mark it right there and do the same on the other side. Okay, so take a deep breath and then hold it there. Hold it while I'm percussing. And then have the patient take a deep breath and exhale, and take a deep breath again and exhale and hold. Once the patient has completely exhaled, I can start over again and have him start and I can start all over again. It's either you can do going up again, or you can just start where you have where your fingers are. So Kai, do it again. So when I percuss up, where it sounds from dull to resonance, it's the same thing on the opposite side. They should be equally from side to side. Mark how and where the change in dullness is. So the change in the dullness is what we call the diaphragmatic excursion. So it is the amount of the diaphragm moves during the inspiration and the expiration. And that should normally be between 3 to 6 centimeters. And for someone who is well conditioned or an athlete, the lung should be in shape and can sometimes be between 7 to 8 centimeters. So next is to palpate the back structures. First, you have to palpate for any tenderness, any pain, and just looking at the structure, if it's symmetrical, but similar as what I did in the front, like just looking for any abnormalities. So I'm going to use the palm of my hand by inspecting the area. And I'm just gonna look for, like, you know, when he breathes, if it's symmetrical. So as what we did in the anterior side, we also check for the tactile fremitus. So I will have the patient say 99 while I'm using the palm of my finger clockwise, in a clockwise position in all 4 sides. Kai, can you say 99 while I'm checking the tactile fremitus?
99, 99, 99.
scapula, you don't really hear any of the vibes, or you don't even feel any of the vibration in your hand. But over the lung fields, you feel good vibrations. Even more importantly or significantly than that, the fact that you can feel that they are in the same side, and they are same from side to side. So another part of the palpation is to check for lung expansion, for symmetrical lung expansion. So I'm going to put both of my hands around the 10th rib. And I'm making sure that I will have this little space here with my thumb, with my thumb. And then I will have the patient take a deep breath and then exhale. Do it again. Exhale. Okay, so again, as he takes his deep breath, my thumb should go with him, and then you can see that the thumb expanded together once he exhaled. They should be equally going up and equally fall back down. So that's what we call the chest expansion. Finally, we are going to do the auscultation of the posterior aspect of the lungs. Similar as what we did in the anterior side, it is important to check one side and compare it to the other side. So whenever you feel my stethoscope touch your back, I will have you take a deep breath in and out, and then I would in and out, and then I will check underneath your arms as well. So I want you to stretch your arms out, and then I will start I will start listening to your lungs. Inhale. Inhale. You're listening for normal lung sounds, which is on the posterior aspect of the chest. Mostly it's going to be vesicular on the anterior side. You can get some tracheal sounds up via the trachea, and you can get some vesicular sounds up in the anterior portion of the chest. But the majority of the lung fields, you should be hearing vesicular sounds. You are also listening for advantageous sounds, which we call the abnormal sounds. And this includes the crackles, which are going to be coarse sounds, and are oftenly described in the literature as the sound of your hair crinkled in the front of your ear. It's like a snap, crackle, pop, that they can be really coarse and they can be fine. One of the abnormal lung sounds is what we call the wheezing. Wheezing is an abnormal lung sound, and it's common with asthma. Some of the bronchitis syndromes and air is in during the inspiration and expiration. So air is trying to get through the bronchial that is constricted, or there is some mucosal edema. As the air goes through that constricted vessel, it produces the whistling sound. So you might hear the whistling or the wheezes of the lungs, as well as, when you finally hear some bronchi, which are the coarse sounds. There are rough and hoarse sounds that you may hear in the bases or all throughout the lung fields. There are a couple of special tests that we do if you suspect that your patient have pneumonia or some consolidation. If the patient is complaining of coughing or pain when they are, or complaining of chest pain, or hurting when they are coughing. So you can perform a couple of tests that we call the voice transmission. One of them is called the bronchophony. Whenever you listen, place the stethoscope on the patient's chest, have the patient say 99, and listen for what you hear. So I will place the stethoscope on the patient's chest, and I will have Kai say 99 while I'm listening to the four sides clockwise.
99.
Wait. Okay, go ahead.
99. 99. 99. 99.
Okay. So if you hear the little bit of change, you will want to compare it to the other side. Usually, the voice should be muffled and indistinct. You will not necessarily hear him say 99 very clear. If there is some consolidation, you will hear 99 just like you don't have a stethoscope in your ear. It will be more clear and more distinct. So another one of the tests is what we call the whispered ventriloquy. So here I will have Kai say 99 in a whispered, but in a whisper. So Kai, every time I place my stethoscope on your chest, I want you to whisper 99. I will do it as the same as what I did in the first test. I'll do it clockwise, okay? Sit up. So I don't really hear him, but I can see him like whisper. Like I can hear him whispering. I can see him saying 99. So normally you cannot hear the patient. Normally you can hear the patient's lungs through your stethoscope. That means he has consolidation. So if you can hear him saying 99, but you can't hear anything which is normal, but if you can hear the patient's lungs through your stethoscope, that means that he has some consolidation, because sound travels better through consolidation. That is why we would hear it better. His whispered 99 actually comes out clear when I'm listening to the patient. So the third test will be called egophony. So I will listen to the patient's lungs with my stethoscope, and I will have him say E every time I touch the patient's back clockwise. Okay, so when you feel my stethoscope, I want you to say E, okay? Go ahead.
E. 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 E.
So you should hear A or E, A or A for what we call the E to A changes, and that indicates that there is some consolidation in the patient's lungs. You did the exams on all posterior aspect of the chest, but you should do them on the posterior anterior lung field as well. So you will hear a different sound in the posterior aspect of the lungs, which is mostly the lower lobes of both of the lungs. Sounds on the anterior chest are coming from the upper lobes, and you get the sound of the upper lobes on the right. So you get the middle along the anterior chest line. So that concludes the lung and thorax examination. Thank you.